chairpersons, friends, uh, we have today the Professor John Ocean oration. We all know that John Ocean, I'll tell you briefly, I think it has been told, but he was the father of materiovigilance, a pharmacologist, a toxicologist, a biomedical materials expert, and he established the US FDA guidelines and regulations for medical devices. So this was the work that he did in 1960-61, led to the establishment of these guidelines. And he was from the Temple University and the University of... So coming back to Professor John Ocean, who was the father of materiovigilance, a pharmacologist, a toxicologist, biomedical materials expert, how plastics and how metals and valve implants and, at that time, open heart surgery was being recognized in a very, valves were being replaced, people had rheumatic heart disease, and those implants were going to be there for life inside the body. So his basic philosophy was, and I'll just read out one or two points. He said a large number of medical, dental, and pharmaceutical advancements have been made with new plastic materials, artificial heart valves, specialized packaging systems for storage and delivery of medications. So he said that a proper program should be done to evaluate the toxigenic properties, to evaluate whether the agent itself or its chelated properties, or once the blood comes in contact with it, then the released materials, whether they are teratogenic, mutagenic, or carcinogenic. And therefore, he said that various tests that are employed, whether this is going to benefit or the risk. So that risk-benefit ratio was what he said should be established for every device. What is the life of a device? What is going to be the problem with the device? And what is the materials that are going to be harmful? So he published these papers, the classic papers in 1960 and 61, which later on led to the US FDA regulations for medical devices.
Hello.
And I think that is one of the greatest contribution that has happened, as has happened for pharmacovigilance, for drugs vigilance. This was materiovigilance, which was established, and now we have other things like vaccines and other diagnostics, which needs to be also monitored properly. So now I will come to the topic of the oration, which is the India's COVID vaccine saga. And I think what was the role of the Indian Council for Medical Research. Now, if you all know that on the 31st of December, or rather the 30th of December 2019, there was this deputy editor of ProMed, which is a program trawling internet chatterbox. From that internet chatter, they reported 4 cases from the Wuhan Public Health Commission report. There is certain pneumonia which is there, and suddenly 27 cases were reported. And then Marjorie Pollock issued her own appeal to ProMed Network. And within hours, because of artificial intelligence and because of the internet, the artificial intelligence system at Boston Children's Hospital issued an alert, which is the seriousness of 3 out of 5, that there is something happening. And 80,000 subscribers of ProMed were immediately, within a matter of seconds, across the world, were activated to this problem, that there is some pneumonia. And this was 30th of December 2019. And after that, in 2020, how I got into this, I'm a cardiologist, that too an interventional cardiologist. And how big was the beast? What was the behavior of this virus? What was the biology of this virus? We all didn't know. What happened was that on 6th of January, or rather 7th of January, the Ministry of Health, Government of India held an urgent meeting that this virus has happened in China. What should we do? What should be the discussions? And on 26th of January, we had one patient. So which and this whole story is mentioned in this book, which I have written called Going Viral, through the aegis of the ICMR, which is, you want this? I think everyone can you hear me? Yeah, I think that's okay. So what is the ICMR? This is the Indian Council of Medical Research, which was also known as the Indian Research Fund Association, established one of the oldest scientific research bodies in the world, actually.
Recording in progress.
And in 1949, this was renamed as the Indian Council for Medical Research, and it had done several groundbreaking discoveries. Right from the 1918, the Beriberi inquiry was done by them during pre-independence. Then 1938, malaria survey was done, and Ronald Ross subsequently did work and got the Nobel Prize. Kala Azar cycle was, again, by Leishmania Donovan, was documented while working at this organization, and he got the Nobel Prize. Then the domiciliary treatment for TB, the short-term treatment, the first oral polio vaccine trial, the low-calorie malnutrition and the protein energy malnutrition myth was bust by my predecessors at the ICMR. And then oral rehydration therapy in 1970 was established, and you know that Pradeep Mahanalabis was awarded with the Padma Bhushan this year for his discovery on oral rehydration therapy. India's first test tube baby, which was the second test tube baby in the world after Edinburgh, was done in India, and much of the work was done in Calcutta. And then double fortified salt in 1994 for iodine deficiency, hypothyroid. So this was the major work that was done in ICMR. Now, what happened on the 26th of January, I was telling you on 2020, there was the first case of COVID-19. This case was a medical student who traveled from, traveled from Wuhan to Hong Kong, Hong Kong to Calcutta, Calcutta to Bangalore, Bangalore to Cochin, and then by bus to his hometown. And this medical student developed fever and was diagnosed by the National Institute of Virology unit in Alappuzha in Kerala on the 27th of January as COVID-19. And that was the very first case of COVID-19 in India, and was reported to me at 10 in the night that this is, and I had to break this news to the government that yes, this virus has entered our country and we are also vulnerable to this virus. Before reporting, I said the sample should be sent to the National Institute of Virology in Pune, which is the first BSL-4 laboratory in the world, in Southeast Asia region, established in 2010. It is a biosafety level 4 laboratory, and the Wuhan lab is the second laboratory in Southeast Asia, which is established in 2017. So we confirmed the diagnosis and reported to the government, yes, this virus is definitely COVID-19, and we in India are vulnerable to this, and we need to take precautions. And all the contacts of this patient, working backwards, right up to Calcutta, were screened and isolated, right from the bus ride from his hometown to Cochin, flight from Cochin to Bangalore, Bangalore to Calcutta. They were all isolated and identified and isolated at that point in time. So that was done through the help of ICMR and the Ministry of Health, and I was put into this because there was only one diagnostic laboratory in the country for COVID-19 at that point in time, and a cardiologist was asked to look after the virus problems. Now, what happened was that during the COVID pandemic, we used to have regular meetings, and we realized that COVID had reached our shores few months later compared to the Western population. There was havoc in United Kingdom, there was havoc in Italy, there was havoc in Iran, there was mortality in Spain. Many of them embraced herd immunity, which did not work, and we realized this. So we got learnings from what was happening in the Western world. So So we said that we need to impose some sort of a restriction in the country, whether it be by flights, and then the expert monitoring committee was formed by the cabinet secretary, which was meeting every day. We had shortage of diagnostics kits, we had shortage of PPEs, we had shortage of face masks, we had shortage of oxygen. All those things we realized, and there was a subgroup created for each one of them under the cabinet secretary at that point in time to look at them and try to uh, uh, find out solutions for the nation. Over and above the group of secretaries, there was a group of ministers which was constituted, and they were also meeting every week to decide what should be the next course of action. Like on a war footing, it was being done, and the leadership was monitoring everything day to day. So, our COVID pandemic was that our leadership was serious from the beginning. There was a whole of government approach, including all the ministries, all the organizations, and it was a calibrated, proactive, preemptive, graded response, which was based purely on science, and it was science-driven with the presence of a strong leadership with excellent communication, taking all the states along, all the chief ministers of all the states along, and informing them, having meetings, VCs, etc. with them. So our philosophy was based on test, track, treat, and not herd immunity, which led to a large number of mortality in Sweden, United Kingdom, Spain. We did not embrace herd immunity at all. We believed in isolation at that point in time. So if I were to summarize what were the 10 COVID-19 highlights of the Indian Council of Medical Research, they were the following. Number one was the countrywide scaling up of the testing network from 1 laboratory to 3,000 laboratories in the country. Diagnostic kit self-sufficiency. I'm talking about February 2020. We didn't have diagnostic kits. We were asked by countries like China to purchase in a matter of hours, otherwise they will divert it to some other country. We had to take decisions in a matter of minutes to buy those kits. So we decided that we will develop our own kits, and by March, April, we were able to have our own startups develop these kits, and by July, August, we were exporting these kits to many parts of the world. So that was an example of self-sufficiency. We did the nationwide sero survey, the largest sero survey in the world, 4 rounds of that survey. The first round was done in May, and we'll talk a little bit about it. We did the validation and diagnostics, local manufacturers, indigenous vaccine development, which I will talk in more detail, the phase 3, from the virus isolation to the phase 3, preclinical animal studies to international research, more than 300 research publications on COVID-19 with all Indian authors, and that was my philosophy for them was very clear. Whatever work you have done, please document it, and document it fast. Otherwise, and we were able to get 300 publications in top journals across the world. Treatment diagnostic guidelines, which we talked about, the social behavior research, stigma, vaccine hesitancy, innovative service delivery by drones, and I'll talk about that also. So coming back to the BSL-4 laboratory and the diagnostic kits, so this was the first BSL-4 laboratory in Southeast Asia, which was developed by the first in India, and my predecessors had set this lab up, and the second lab was the Wuhan lab, which I mentioned, which was developed in 2017. And this is a repository of all the viruses that are there. We need to remember that much as per the international treaty, the smallpox virus was destroyed in India, but one sample is remaining in Russia and one sample is remaining in the United States. So they still have the smallpox virus. There are several laboratories across the world which are looking at viruses, and the repositories are there. So February, we had this group of secretaries, and on 9th of March, we were the 5th country in the world to isolate the virus. We tried to get the virus from the WHO. Every country was wanting the virus. They were not there was not much communication and supply to different countries. So we were able to, there was a group of visitors from tourists from, I think it was from Italy, who were visiting Agra and Rajasthan, and they were admitted with COVID-19, 11 tourists, and we were able to get samples from them through our ICMR network. We immediately got the samples every day, and from that we were able to culture the virus and isolate the virus, and on 9th of March we were able to isolate the virus. We were the first country in the world to isolate and culture the alpha virus and the beta virus, and they've all been published in top journals, Journal of Travel Medicine from Oxford. And then in terms of testing, February we had only the RT-PCR tests, and as I mentioned, we were approached by different countries that these are limited number of kits available. WHO was able to supply us some 10,000 kits at that point in time. For a country of 1.4 billion, it was just a drop in the ocean. It was difficult. So at that time, we said we have to be innovative, and we said that we'll repurpose our TrueNat machine. The TrueNat machine is an indigenous molecular diagnostic portable machine for tuberculosis testing, which was developed by the Indian Institute of Science and funded by the Department of Biotechnology, CSIR, and investigated, and WHO pre-qualification and multicentric trials, multinational trials were done by ICMR to get it a WHO pre-qualification for tuberculosis in 2017, 2018. And this machine for tuberculosis diagnosis, 8,000 of such machines were already there in different parts of the country. So immediately in February, March, we repurposed, because we had already repurposed it for Nipah virus and leptospirosis for the first time in the world, this molecular diagnostic kit. So we said, let's do it for COVID-19. And within a matter of few weeks, we were able to repurpose this machine. So immediately, 8,000 of these machines were available for COVID-19 testing. But the problem was that this can test a very small number of samples in a day. At one time, 4 samples, and then some machines had 16 samples. So this TrueNat machine was upgraded in April of 2020. And then in June, when we had the first wave in New Delhi, June of 2020, the first wave in Delhi, we said that we'll use the antigen kits. And Korea was the first country to use antigen kits. And we said that we will start using it, and then can we have the slides? What is happening? It's coming, okay. So they are there, anyway. So then we used the antigen kit for the first time in India, and in June, and by September there was testing available, and we were exporting kits by June, July. The TrueNat molecular diagnostic kit that we were using was first by India. The United Kingdom developed another kit called DNA Nudge, which was available in September, much later than what we had started. So we were ahead from that perspective in being innovative for the diagnostic kits. So 700 million samples have been tested, I think much more now. This is a slightly dated slide. And the cost of one RT-PCR test was $2 per kit, and the rapid antigen kit was $1 per, compared to $200 outside in many parts of the world. And much of the labs, 39% of the labs were working on one shift, and 32% of the labs across the country were working 3 shifts. All the data of testing was available at ICMR, was being sent to ICMR on a daily basis, and that was available and for analysis later on I'll talk about. So this is the upscaling of the TrueNat, which was done across the country. And on June 9th, 2020, we also had discussion in ministry and said that we will ask all the medical colleges to set up a BSL-2 laboratory. Otherwise, they would be, if they have to keep their registration alive. So we were using the carrot and stick at the same time. And 30 odd medical colleges were able to start that immediately, very fast. And then comes the story of 9th March, we isolated the virus. Several times we mentioned to the Cabinet Secretary in the group of ministers meeting that we need to impose international travel restrictions. And then I was requested by the Cabinet Secretary that please make a document on a 1-page that what do you want should be done for the COVID pandemic in March, on 10th of March. I said, we had some consultation and we decided, and I wrote 2 lines on that one page: impose travel restrictions for all international travel, number 1, and number 2, impose lockdown so that we can develop our health infrastructure and repurpose it and improve it during the time, because then there will be less movement. And I think this was on, I think, 18th of March, I was requested to present before the leadership. I took 5 slides and presented that this is a problem and we need to have this. We belong to a generation of people who have dealt with Jai Jawan, Jai Kisan and food shortages in the 60s and the PL 480 program, the Colombo plan. So we will be able to manage without food. We will manage, and we told this to the leadership. And the next day we had that the Janta curfew and followed by the lockdown. Now this was 22nd of March, and during the lockdown, the ICMR became the nerve center for the testing, for the kits, for guidance, for policies. We had the IB sitting there, we had the research analysis wing, we had the Ministry of Civil Aviation sitting there, we had Indian Railways, we had Indian Air Force, we have this headquarters in New Delhi, where we were providing, we had about 40 scientists from 27 institutes consisting of epidemiologists, pharmacologists, microbiologists who were called, and they were stationed in a lockdown at the ICMR guest house in the Asian Games village, in the 40 rooms there, and they were working at the ICMR headquarters continuously from in the morning till 12 in the night, guiding at every level. And I think kudos to them for working so hard at that point in time. And this, during the lockdown, we had 4 phases of that. We had special flights commissioned for taking even 1 PPE kit to one small village by helicopter, and that was all coordinated through the ICMR, and all the kits delivery at all the places was being done at that point. Continuously, group of ministers and group of secretaries had regular meetings on PPEs, how India's textiles, how should we be self-sufficient in our, and that happened very rapidly, a whole of government approach where we were able to, within a matter of weeks, become self-sufficient and also start exporting to many parts of the world. So now the lockdown, because of the leadership, the lockdown was so effective that it was a Buddha's middle path, I would say. It was not like the draconian lockdown that we had seen in some parts of the world, or the liberal lockdown that we had seen in other parts of the world where no one listened to the lockdown, and people were all the time. So we got valuable time to prepare for the worst, which was yet to come. We were able to set up PPE kits, we were able to set up masks, we were able to set up makeshift hospitals, we were able to set up quarantine centers, the ITBP, the Ministry of Defense, Hindon Air Force Base, Jaisalmer, Jodhpur. We developed all kinds of quarantine facilities, which were blankets and food and lodging, and for quarantine for people returning from different parts of the country. And India was doing a mission of bringing our students back from Wuhan, from people who were stranded in the Princess ship in Japan, from Italy, because there was a huge big problem there. And more importantly, what we learned from the lockdown was that we took the knowledge from different parts of the world and assimilated it for making and tweaked it relevant for India. Now, another small story I would like to tell was during the lockdown, February 2020, again, just before the lockdown, we had about 6,000 of our Shia pilgrims who were stranded in Iran. And we were asked that we have to get them back immediately. Then there was a discussion, how do we get them back without testing them? So again, ICMR is the testing laboratory for the country suddenly. So why not ask ICMR to set up a laboratory in Iran? within 24 hours, we were given strict instructions that set up a laboratory in Iran to test those pilgrims and get them back. Passports were issued, equipment was gathered, and lo and behold, how the Indian machinery works like magic. And I think the bureaucracy, kudos to the bureaucracy, how where we were issuing guidelines between the health secretary and myself every day, and on the bottom writing to all principal secretaries of all states and union territories, to all chief secretaries of all states and union territories, and before 12 p.m. this guideline would go to them, and next morning the action would start. It was like a well-oiled machinery, and I think kudos to the bureaucracy. As medical professionals, we do not realize how the command system works in the bureaucracy, and that was fascinating, how we were able to leverage that. Similarly, the passport was issued within, and the visa, and the tickets, and the scientists left within 24 hours with all the equipment, with special flight, and they were able to set up the laboratory. Now, how to set up the laboratory in Iran? They had shortage of testing kits. They had people dying there. You can't set it up in the public there. So it was set up in the basement of the Indian embassy in Iran. And we tested those people, and all those who were negative were flown back immediately by special flights of the Indian Air Force and the Iranian Airlines. And the rest were kept there in quarantine for some. And these people who arrived were kept in quarantine in these bases which were specially created at Hindon, at Jaisalmer, at Jodhpur, and many others. I don't even remember now, again with ITBP Defense and the DGAFMS. So it was a whole of government machinery which worked like absolute magic, and how we were able to get these people back. Now, if we look at before the vaccine, what were the treatments available for COVID-19? Well, only 3 treatments are of significance which the world contributed. By science, number 1 was the use of steroids, which was done by the recovery trial by the United Kingdom. And they demonstrated that steroids are working and they can be given. The second was the use of remdesivir, that it reduces the hospital stay by the WHO, and we were also participant to that multicentric trial, and that demonstrated that the days of hospitalization was reduced by remdesivir. So United States contributed to the remdesivir trial and through WHO, and the recovery trial was contributed by and answered by that steroids are working by United Kingdom. And the third greatest innovation that clearly was done was by India, which was clearly demonstrated by a randomized trial, clearly showing that convalescent plasma is not working. This trial was done during lockdown by VC. We had democratized research. We had taken district hospitals. They were doing this trial, a trial for the very first time, and we guided them on a daily basis by getting all the ethical approvals. 39 public-private hospitals and 464 patients were randomized to convalescent plasma and placebo, and we clearly demonstrated that this is not working. The registry of the Mayo Clinic of 100,000 people was saying that possibly it is working, but this was clearly a final nail in the coffin that convalescent plasma is not working. It was established by ICMR, and this was published in the BMJ with 2 editorials on it, how India democratized research and how research was done by people who had never done research before, but guided by VC, and we were able to show that. So these were the 3 pharmacological contributions: steroids working, convalescent plasma not working, remdesivir plus minus reduces the hospitalization. I think that was before the vaccine that was really demonstrated, and India, United States, and WHO and United Kingdom contributed to that scientific literature. Now, surveys and epidemiological studies. So during the lockdown, we had certain pharmaceutical agencies like Cadila and others who were going by car from Ahmedabad to Pune. They took the virus and we raised antibodies, and we were able to develop the ELISA kit for diagnosis within a matter of few weeks, this ELISA kit was done, all during the lockdown, people traveling by car from Ahmedabad to Pune, and at the NIV laboratory, and also the laboratory in Kerala and other laboratories in Gujarat. And this was the first indigenous kit called COVID Kavach ELISA, which was used for the largest serosurvey done ever in mankind, 29,000 patients, which clearly demonstrated that May, June of 2020, that prevalence was only 0.7%. 99.3% of our population was still vulnerable for COVID-19, and therefore we need to observe all the quarantine measures and all the isolation measures that have to be done. So this then we did the second round and the third round and the fourth round of serosurvey, where we clearly demonstrated that the children and others, how it went up to 66.7%. And these were again published in top journals: Lancet Global Health, International Journal of Infectious Disease, Indian Journal of Medical Research. Now coming to the vaccine. Now, we had isolated, as I mentioned, the virus on the 9th of March. We had an MOU, we had an expression of interest and an MOU, and then we were approached by Bharat Biotech that they will be able to develop the vaccine. Around the 30th of April, we were able to give them the virus, and they were able to give us the vaccine. Now, 30th of March, we were able to give them the virus and have the agreement, and then we were able to get the vaccine in the first week of May. One candidate vaccine was given by Bharat Biotech in the first week of May. In the middle of, we had got the vaccine, we did testing on, and this collaboration was based on trust, transparency, timeliness, and mutual respect. And we realized that the time was demanding, and it was very essential to develop this vaccine. Now, from the ICMR's perspective, we said we will follow two paths. One is the international vaccine that is being developed by Oxford. We'll be happy to do their studies in India, in-country supply and in-country validation. We also, at that point, they were talking about human challenge studies to be done, which we did not allow at that point in time with them, that we will not allow giving the virus. We do not know how deadly the virus is, so we will not be able to do the human challenge studies. We were approached by Oxford for the same. We said definitely not. They said that we will do an international study on human challenge study, and they will be citizens of which country? So they said we'll take from different countries and put them on a ship and do human challenge study on a ship. So they will not belong to any country at that point in time or any land. So they will be on water. But that plan did not happen, and human challenge studies were not done. We were against it from the ICMR, and we said we will not participate. So the first route was to get the international vaccines for technology transfer, to do their bridging studies and augmentation for global. And at that time, Serum Institute was working with Oxford, and they were also approved. Before Oxford had given it to AstraZeneca, they were in talks with us to collaborate with Oxford. They wanted the virus also, because at that point in time, we had a large amount of virus isolated, cultured, and grown. The second way, we said that we will develop our own technology, and own technology was to develop our own vaccine. And as I mentioned, Bharat Biotech was the one which we were had the vaccine candidate by May. Middle of May, the leadership took a meeting on vaccines of 2020, which vaccines are being developed by which institutes in the country. And I had not told anyone that we are developing this vaccine at that point in time, because it was very preliminary. So when we had the meeting of the leadership, all the science agencies presented that they are working with University of Minnesota, with University of Washington, with University of Wisconsin, University of Madison, and we'll develop that vaccine, we'll develop this vaccine. At the end of the presentation, I raised my hand. I was asked by the leadership, yes, Bhargaw ji, what do you want to say? I said, sir, हम लोग एक देसी वैक्सीन बनाने की कोशिश कर रहे हैं. भारत बायोटेक के साथ हम लोगों ने उनको वायरस दिया है, कोशिश कर रहे हैं. वो स्टैंडर्ड टेक्निक से किल्ड वायरस टेक्निक की वैक्सीन है, कोशिश कर रहे हैं. और यदि कामयाब होगी तो हम आपको बताते रहें। उनका करिए, आप आगे करिए इसको. And after that, there was no stopping from any perspective, and I'll come to how we were able to develop this vaccine. The vaccine candidate was there. We did the preclinical studies again at ICMR on several institutes, testing the safety on small animals, safety, immunity, and the dosage. And we published that because we had a new adjuvant for this vaccine. These papers were published in iScience with a cover story regarding this vaccine, that this is a new adjuvant that has been used for the first time in the world, and by an Indian inventor. In the US, we had got that adjuvant. The vaccine was developed by Bharat Biotech. We had given them the virus, so it was again a full private-public partnership. We did the small animal studies. Once we were able to establish the safety, immunity, and dosage, I hope I'm in time. We have another 10 minutes or so? Yeah? Okay. So then once we were able to identify the safety and immunity and the dosage of the vaccine, we had to do large animal studies. Now, large animal studies is another huge big story, because monkeys are not being bred in India for a large number of years because of animal activists in the countries. And I received several letters, phone calls, threatening letters from various animal activists that why are you... so we decided that we will capture monkeys from the wild. Now, how to capture monkeys from the wild? We got again, the government moves like this if it wants to move. Within 24 hours, we got permission from the environment, forests, and everyone that yes, you can capture 24 monkeys, and that will be taken. Those monkeys can be used for testing. And we got a team, assembled a team, and the team could not capture the monkeys in the cities because there was lockdown, and there was no food available. The monkeys had gone to the forests, so we had to go to the forests to capture those monkeys. Now, to capture those monkeys from Pune, went to Maharashtra border, Telangana border, Karnataka border, and within a matter of a week, we were able to capture 24 monkeys, got those monkeys, and took them to the biosafety level 4 facility, where we have air-conditioned cages for monkeys in that facility, which is heavily security guarded. You cannot enter the BSL-4 laboratory in Pune without security and no normal. There is negative pressure because the people who are working on the virus need to work in negative pressure suits, and then there are air-conditioned cages. So there we got the monkeys, and we did the monkey trial on those monkeys. I'll tell you more details about that. And then after the monkeys, we had to test whether these monkeys are healthy. So how do we test whether the monkeys are healthy? So we had to buy an X-ray machine. At that point in time, the cabinet and had issued an order that certain purchases before 31st of May can be made without all the tendering process. So we were able to leverage those finance rules and buy an X-ray machine in 24 hours and screen those monkeys, get all their blood tests done, and then put them in air-conditioned cages and show that they are safe. So how to do the monkey trial? Those monkeys have been captured, they are in the air-conditioned cages. How do we do the trial? We gave them the vaccine. We gave them the vaccine, and now we have to challenge them with the virus. Now, how do you challenge them with the virus? You have to anesthetize the monkey, you have to do a bronchoscopy of the monkey, and give the virus in the 3rd generation of the bronchi, release the virus inside the lungs, and then do a bronchoalveolar lavage every day in anesthetized monkeys for the next 7 to 14 days. Who will do the bronchoscopy of monkeys? Where do we get the respiratory surgeon? We had one pulmonologist, DM pulmonology, as a scientist D, who had joined recently at our center, at the headquarters. Sent him by a special IAF flight to Pune. We talked to the army chief, and he asked the CTC Pune to arrange one pulmonologist. This is all during the lockdown. No one is moving in the cities. We asked those people. They were again locked in the NIV Pune Guest House, National Institute of Virology Pune Guest House, for full 1 month. These two pulmonologists and their teams were locked there, and they were doing the animal studies in the month of June, May, June, in those monkeys, which were captured and proven healthy by records. And bronchoscopy every day, given the virus, and then bronchoalveolar lavage for 14 days. And at 14 days, what we found, that the virus had not grown. So that was the turning point where we realized that our mission was successfully accomplished and we can go to humans with this vaccine. These results we had in the month of June. We had these results. And we started the phase 1 on the 15th of June in humans, which was a clinical trial safety, which is published in Lancet. Then we did the phase 2, and then the phase 3, and then WHO pre-qualification, then the EU qualification. US FDA was in process, and the Canadian FDA approved it, and we were marketing this vaccine, or marketing rather, giving it this vaccine. Now, this monkey trial had to be published. So we sent the paper to Nature. And during this time when we were doing the monkey trials, I had received several threatening letters and phone calls from agencies that we are told that you're going to capture monkeys. And I told them I had already captured the monkeys. I told them, no, I am not going to capture monkeys. Ashwatthama Hado, wali story. So I am not going to capture those monkeys. Anyway, but we have done some work which we are sending to Nature. They came to know that we are sending the work to Nature. They wrote to the journal that these are monkeys not from a breeding facility, and they cannot be, this paper should not be published. India working against India. We sent the health certificate of each and every monkey to the journal, and finally they published this data in Nature. And interesting story I want to further add. The Oxford vaccine, or the serum vaccine, the Covishield, was a vaccine developed in United Kingdom with the monkey trial done in the United States with the monkeys imported from China. So China is the largest exporter of monkeys and now is the largest importer of monkeys from Sri Lanka. You must have read about that. Because the Sri Lankan economy is in bad state, so they are exporting about 1 million monkeys to China, because they have to do testing of safety, pharmacovigilance of drugs, cosmetics, vaccines, all being done in China. Each monkey used to cost about $500. Now, after the Ukraine war, each monkey costs about $4,000. Because China has stopped exporting those monkeys to America, and it's $4,000. India, during this COVID-19 pandemic, we were able to set up a huge breeding facility, which is called the National Animal Research Facility in Hyderabad, in the Genome Valley. 29 buildings of breeding facilities of rats, mice, right up to horses. And we've been breeding monkeys now, hundreds of them there in Hyderabad. And that is a state-of-the-art facility. Ever go to Hyderabad, you must visit that. Absolutely the best in Southeast Asia. And we also have a breeding facility near Bombay, which was initially funded by NIH in 2004-05, was stalled, nothing was happening. That has been reactivated, and that is also now going. So that is the monkey story, which is in the part. And then we did studies for Zycov-D and the first world DNA vaccine, which was developed by Cadila. We had done all the clinical trials for them. We said that they should not be used in children. They had intended them to be used for children, but when ICMR told, no, not for children, the ministry listened to us, and they were not used for children. And then we did the first studies for Alpha, Beta, Delta, and Omicron, various comparisons with Covaxin and Covishield. And the Covaxin phase 1, phase 2 was done. And the new clinical trial rules of 2019, before COVID pandemic, said that if, I'll just come to that anyway, we'll come to that. So this was in 2020. March 9th, the virus was isolated. May first week, we got the vaccine candidate, completed the large animal studies in June. Phase 1 started in July. Phase 2 completed by December. December 16th, the first vaccination happened in the world, in the Western world. 3rd of January, the DCGI gave approval for the Indian vaccines, and 16th of January, 1 month later than the rest of the world, we were able to give vaccines. And 3rd of March next year, the leadership took the vaccine, and then the Indian vaccine was exported to more than 98 countries across the world. A stamp was released for this vaccine, postal stamp, and it clearly established that India is a pharmacy of the world, but now a vaccine superpower, wherein Indian vaccines were being manufactured. 60% of the childhood vaccines through the UN and WHO systems were being exported from India in the past. But here we went with Covaxin, we've proved that we could manufacture vaccines from start to finish, purely indigenous, developed in India, by India, for India, and for the world. And this was a success story which clearly established that private-public partnership should be scaled up, not only in healthcare, but in other areas wherein we could manufacture the vaccine. Now, this is another interesting slide which I wanted to show, because in 1947, we had this Rajkumari Amrit Kaur receiving a box from the High Commissioner of Canada. And in this box, after the Second World War, is a box of, anyone? Is a box of penicillin injections. Penicillin was the first antibiotic developed. Canada contributed a box at that point in time, that this is a gift from Canada to India in 1947, and in 2021 we were able to gift the Indian vaccine to Canada at that point in time. So that was reversed because it was a critical and timely government support, right from funding to preclinical studies and a private-public partnership, to clinical studies, to laboratory studies, to epidemiological studies, to rolling regulatory review by the drug controller, advance purchase orders, at-risk manufacturing, raw material import, and expedited batch testing and release. And batch testing facilities were scaled up not only from Kasauli, but to Delhi NIB, to institutes of DBT and ICMR in Hyderabad, and also in Pune. So now we have batch testing facilities in different parts of the country. Now here I want to put you into the new clinical trial rules which I was mentioning, that these were approved in 2019, that when there is a life-threatening or a serious disease condition or rare diseases, for drugs that are intended to be used is in unmet medical need, then phase 2 is good enough to give approval in an emergency. And we leveraged this, which was criticized by a lot of activists, was criticized by a lot of people who were not in the game, that this is, and various competitors of within the country were criticized ICMR and the Ministry of Health and the Government of India for leveraging the phase 2 for approval, but we did not see any serious problems with that. Now coming back again, I'll take you back to March before the lockdown. On 18th of March, we constituted a committee which was called the National Task Force for COVID-19, which I requested the Health Secretary to be my co-chair, and requested the Planning Commission chairman to be the chair of that committee. This had 43 to 45 specialists of virology, epidemiology, pharmacology, and microbiology, who were discussing every day different new drug that came, was discussed. Should it come to India or not come to India? Should we develop it in India? Should our Indian manufacturers go for this or not? And therefore, we were able to not let a large number of unnecessary drugs or treatments go into our system, whether it be Western vaccines, which were very expensive and had several indemnity and other issues, which we were able to stall for many months, and certain drugs which were not going to be effective in the public health system of India, where things like molnupiravir, 2DG, coronil. So we were able to stop a large number of those drugs and show that they are not working by our advisories, and in our advisories we did not include those. And this task force was informed to the Supreme Court of India on the 18th of March 2020 that this is the national task force, this will be guiding it, and that issued the various advisories and management protocols, which we have all seen across in different languages. Now, research publications, we had 6 issues. These are 5 and 1 more issue, 6 issues of IGMR on COVID-19, and 300 research publications, right from Nature, Science, PMJ, Lancet Global Health, to various virology journals on epidemiology, on modeling, on pharmacology, on vaccines and animal studies, were all published with not a single Western author as part of these 300 papers. So that clearly showed that we can do it in India together if we work together. And the impact factor of the Indian Journal of Medical Research rose to 6 from 2. It rose to 6 after the COVID pandemic. And we had we had other issues because there were systematic reviews, meta-analysis, network meta-analysis, living guidelines. We had to take all these drugs like baricitinib and roxutinib and sanilumab and tocilizumab and various other drugs, molnupiravir. We had to weigh the evidence whether it will be useful in the public health system for India rather than just entering without any regulation. And we issued various guidelines for communication, for infodemic management, for community management. We had clearly said that masks are a must, and masks will probably be the last to go. This was a statement made by me 3 years back, that masks will have to be used and continue to be used as long. So we know that vaccination prevents death, not vaccine. And from the national database of CoWIN and the ICMR testing database of 94 crore 47 lakh individuals, partially vaccinated, fully vaccinated, and unvaccinated, we clearly demonstrated that 92% of the deaths during the Omicron wave in January of 2021 were unvaccinated people. So we clearly demonstrated that vaccine prevents death, and this was because of the 28,000 cold chain points. We have been running the universal immunization program through the Ministry of Health for the last 60 years, and one of the largest programs in the world, which has been with 2.3 million ASHA workers and millions of doctors and nurses. Out of these, 350,000 vaccination centers were public centers and 28,000 were private centers. So just 5% or 10% were from the privates. And India became a vaccine superpower. With the IT prowess, we were able to develop the CoWIN app, which was for appointment scheduling and digital QR certificates. Many developed nations were giving handwritten certificates compared to what we had given, leveraging, clearly establishing self-confidence in not only the doctors, the nurses, the paramedics, but every citizen of India who participated phenomenally as self-help groups and local government. I think the Indian population were most disciplined as far as the COVID pandemic was compared to many nations in the world. So during the Omicron wave, we were much better than Russia, United Kingdom, Brazil, USA, Canada. If you look on the left side, in terms of the number of cases, in terms of the number of deaths, are much lower, and we know that the vaccination reduced the case fatality rate. As the vaccination went up, the case fatality rate went down. Now, one more point, interesting point, was when I joined the Indian Council of Medical Research in 2018, in March, April, the very next month there was the outbreak of Nipah virus, which has about 80 to 90% mortality. So we didn't have a BSL-3 facility in the interiors of Kerala. So we said we should develop a mobile BSL-3 laboratory. We approached the WHO. They told us a lot of stories. You go there, we will do this. We approached Europe. They said, we are trying. We have one In the US, they said we have one mobile which goes by flight and that can be reassembled and that can go to remote areas. But we don't have airports in remote areas. And, so from that perspective, we said we'll develop our own BSL-3 mobile laboratory. The person who developed the BSL-4 laboratory in 2011 at ICMR, the first in Southeast Asia, he developed the mobile BSL-3 laboratory. This is state-of-the-art on a Mercedes-Benz chassis from Chennai, and fully steel. If you go inside, negative pressure, there is a shower, there is absolutely like Apollo 11 inside, with all computerized, if you look at it. So this mobile BSL-3 laboratory is parked at Pune, it parked at Gorakhpur, where we had the Japanese encephalitis virus. So when we had the Southeast Asia regional meeting in Paro in Bhutan, this mobile BSL-3 laboratory was demonstrated to all the health ministers of the Southeast Asia region and promised that a gift will be given from India as one of these laboratories after supplying in many places in India to each of these nations as part of soft power of the nation. And all the health ministers of all these Southeast Asia regions participated, looked at this laboratory, and were delighted to see how this is working. So this is now available in India. Then we had the ICMR iDrone project, and you might have read in today's newspaper also. This iDrone project is the ICMR's drone response and outreach in the Northeast, which was a unique, replicable, sustainable program wherein we had some drones. We tested them in the airport, which is at the IIT Kanpur. So IIT Kanpur has an airstrip. And as a student, you can also train as a private pilot license and get a private pilot license. So they have an airstrip which was established by the Indo-US collaboration at that point in time. So we use that airstrip to test the drones and the temperatures and the capability. And then we had an expression of interest. We were approached by 3 companies, and one of them, we took them with our scientists to Nagaland, to Mizoram, to Manipur, and we were able to take the vaccines with the help of the state headquarters, Drug Controller General, Ministry of Civil Aviation, the ICMR, University of Information, Expert Ethics Committee, and the Airport Authority. We had created a separate ethics committee for the COVID-19, which were meeting virtually, based out of Bangalore and Delhi, and was giving approval in 24 hours. Ethics committee approval in 24 hours for projects. They had to do it in 24 hours. And that was, I think, how we were able to test and get various products tested. So this clearly was demonstrated, was replicable, and we had various sorties. Independent showed the sustainability in Andaman, Nicobar, Assam, and we were able to do several sorties in these states, clearly demonstrating land to land, hill to valley, lowland to highland, also from within the big lake. There is the Loktak Lake in Manipur, which is the largest freshwater lake in Asia again. In the middle of that lake, there is a small island which has a population of about 4,000 people. And in that island, there is a primary health center. So from Bishnupur, you travel by 3 hours by road, then 2 hours by boat, and then 3 hours on foot to reach that primary health center. So from Bishnupur, we send the vaccines to that primary health center in a matter of 10 minutes. And now these drones are being used for paracetamol and iron tablets. And today's newspaper is showing how we were able to demonstrate transporting blood from Lady Hardinge Medical College to the Government Institute in Noida, which would have taken several hours. Matter of, we did a feasibility trial, just came out in the paper today, where we were able to, from the same project, we were able to demonstrate how this vaccines. So this vaccine is 4 to 8 degrees, so a minus 70 vaccine cannot be delivered. Pfizer, Moderna, all. So here we have cool packs, and we were able to demonstrate first time in the world vaccines were transmitted by drones and was delivered and We had automatic release mechanisms. One didn't have to go. The drone would fly off after releasing, and you can see how it was released. And I think that is very useful for Uttarakhand region, for blood samples, for other things, and could be leveraged in a big way. This is this little cartoon which is showing the virus that he has gone to a very safe place on the Loktak Island or someplace, and he says the vaccine cannot reach me here. But we have the drone coming here in the second picture, clearly showing that it can reach anywhere, wherever the virus is going to go, the vaccine is going to reach. We had some problems. We lost about 28 of our colleagues from ICMR, technicians, scientists, and people. We remember them and pay homage to them. So I thank you for your attention. For attention is the rarest and the purest form of generosity that you have done on me. I'm grateful to you for that. One more slide. This whole story is being made in a film called The Vaccine War with Anupam Kher as Cabinet Secretary and Nana Patekar as Director General ICMR. And this movie has already been made, is being edited now, and should be available by Independence Day or so. Thank you so much for your attention.